Hello, everyone, and welcome to our WTF series. This segment is on mastering vertical corrections. I'm Dr. John Pham, one of the founders here at InBrace, and I'm joined by Dr. Robert Lee and Dr. Sarah Pai. They're sharing a camera. Dr. Lee has been with us since the beginning of InBrace. He's a biomedical engineer by training, one of the co-inventors of InBrace, and also a clinical orthodontist. And he's joined by the amazing Dr. Sarah Pai, who's a lead orthodontist for us at one of our in-studios here in California. She's also one of the clinical advisors who, if you ever need any help troubleshooting your case, she's likely going to be one of the folks that you talk to kind of help usher you through. So with that being said, this is a webinar format. But by all means, use the chat function, raise your virtual hand, ask a question. We want to make sure we keep it as engaging as possible. And we will have another one of these webinars this upcoming Thursday, October 19th, 9 a.m. Pacific, 12 p.m. Eastern. So with that, I'll hand it over to Dr. Pai.
Thank you, Dr. Pham. All right, so nice to meet everyone. I am Dr. Pai. So today we will be going over, mastering InBrace case types with looking specifically into vertical corrections. So we really do value all the resources and the education to provide and help guide everyone through InBrace as best as we can. So don't forget that we do have our Facebook in group where there's a lot of clinical pearls, and also you can engage in some peer-to-peer learning with everybody else in the group. We have our knowledge base that we have clinical guides and technique videos. And then also we have our InBrace Learning website that has a lot of self-guided virtual courses at learning.inbrace.com. All right, and so just wanted to also announce that we now have our introduction to the fundamentals of InBrace mini residency that is also available on InBrace Learning. It has all the foundational courses that will introduce you to everything to be successful and improve with treatment efficiency with InBrace. So let's just go over an introduction to get everybody on the same page before we dive deep into vertical corrections. So with any modality of treatment, there is different nuances that pertain to each modality. And, they all use standard ortho biomechanics that we're all very, very used to, but there are their respective nuances that will help lead to more predictable and efficient treatment. So we all know that for traditional braces, we spend most of our residency following our faculty, trying to learn their different bracket prescriptions, their wire sequence. They have all of their tips and tricks and pearls with, repos or switching or flipping brackets. And then there's hours upon hours of different aligner courses that go over different, over corrections, different attachment designs, staging, tracking, compliance. So there are lots of, hours of courses out there for these different nuances. So similarly, we have also our systematic approach to InBrace treatment, specifically to deal with smile design, clinical approach, and clinical techniques. And all of these topics are covered in depth in modules 2 to 5 of the fundamentals of the InBrace mini residency that's on learning.inbrace.com. So first of all, we'll go ahead and focus on the smile design. So whenever we approach our smile design, we do want to have a patient-specific ideal setup that has, what you and your patient has gone over to create predictable and achievable treatment goals. After that, you do add in your overcorrections that are necessary to create the proper force systems. And then finally, we go through the clinical approaches that, elastics, bite turbos, things that do clinically chairside that will help support your force systems that you've designed into your smile design. So this is the InBrace Smile Design Reference Guide. It does have every single section broken down in detail and how to approach every section. So you have your vertical, your AP, your transverse, your arch length discrepancy, and then any individual tooth assessments. So they are broken down in sections and color-coded, so they're very easy to navigate through. And then specifically, we will go over all the vertical corrections for today. So when we approach the vertical overcorrection, first step is to measure the initial overbite. And whenever we do anything with vertical, your two best friends will really be your transparency tool and your grid tool. Then after that, you estimate the amount of crowding, spacing, and IPR and how that will affect your overbite. And then finally, go ahead and request for the necessary overcorrections for the overbite and specifying which teeth to extrude or intrude. So just keep in mind though, the general amount of overcorrection for the overbite past ideal will vary between 0 to 2 millimeters. So in this video, you can really see how we go ahead and utilize the transparency and the grid tools. You can go ahead and turn the upper arch so that it's transparent and that you can go ahead and see how much of it is overlapping on the lower incisors and use your grid tool to help measure the amount of overbite. So you can go ahead and count the lines and count the squares and to see what the initial overbite is. In this case, it's at about a 4 millimeter overbite. After that, you'll assess the amount of crowding, spacing, and your planned IPR and see how that factors into the overbite afterwards. And you'll estimate whether the net effect will be by opening or by closing and by how much, so you know how much overcorrection to add. So just a reminder of the biomechanics, when we do have crowding and proclination from that unraveling of the crowding, the proclination will also lead to a relative intrusion side effect. On the opposite side, when you do have any retroclination of the incisors, you end up having a relative extrusion side effect. So when you have crowding, since you have that unraveling of crowding, you have that proclination, it is favorable for deep bites, not so favorable for our open bites. And then similarly, for spacing, when you have retroclination, you have that relative extrusion, which is favorable for open bites, but then not too favorable for the deep bites. So after that, an easy way to remember how much this affects the initial overbite is it's as easy as 2, 4, 6. So between 2 to 4 millimeters of crowding or spacing, you'll get about 1 millimeter of bite opening or bite deepening respectively. Between 4 to 6 millimeters of crowding or spacing, you'll get about 2 millimeters of bite opening or deepening, and then greater than 6 millimeters will translate to about 3 millimeters of bite opening or deepening. So now it becomes a simple calculation. You have your initial overbite that you've measured, and then you have the amount of bite opening or bite deepening that you think will happen per arch based off of your crowding or your spacing. And then you compare the resulting overbite to that patient's specific ideal overbite, and you overcorrect it accordingly within the 2 millimeter limits. So for a resulting overbite that's deep, your maximum overbite correction is to 0 millimeters. And for a resulting overbite that's open, your maximum overbite correction would be 4 millimeters. So this is the first example. We can take a look. We've turned on the transparency tool, and then we have our grid on. So we can measure the initial overbite to be at about 6 millimeters. There's greater than 6 millimeters of lower crowding. So we anticipate a 3 millimeter bite opening effect from it. And there's between 4 to 6 millimeters of upper crowding that we will then translate to about 2 millimeters of bite opening. Your estimated resulting overbite is at about 1 millimeters. So initial overbite of 6 millimeters with about 5 millimeters of bite opening from your crowding. Based off of the actual resulting overbite, the smile design overbite should have been overcorrected to at least 3 millimeters, 3 to 4 millimeters. And you can see in this case, no overcorrection was used. In this case, the smile design was set to be at around 2 millimeters, which then the case shows that it results, you end up with about 0 millimeters of overbite in this case. So after that, once you have decided what you want your setup overbite to be, you then decide on which teeth to extrude or intrude. So this is often based off of different clinical indicators. like the maxillary incisal display, the curve of Spee, and where the crowding or spacing presents. So for crowding or spacing, you want to assess whether the relative intrusion or extrusion is, favorable, unfavorable, and overcorrect that to counter the side effect. In this case, you can see the patient's doesn't have much of an upper incisal display. And based off of the lower crowding, you do anticipate a lot of relative intrusion on that lower arch. So you can kind of think that you will split the overcorrection between the upper and the lower arch. So for example, your instruction to your smile designer can be to overcorrect to 3.5 millimeters of overbite by extruding the upper 3 to 3 by 0.5 millimeters past the ideal and lower 3 to 3 by 1 millimeter past the ideal. So by splitting the extrusion between the upper and lower arches, you are helping to correct and improve that lack of incisal display, as well as address the relative intrusion that you will be anticipating from all of that lower crowding. So try to be as specific as you can to the smile designers on which teeth to extrude and intrude and by how much. Don't let them try to interpret for you which ones they are, because ultimately they don't know all the clinical indications of your patient as well as we do. And so if you allow them to do the overcorrection for you, then it will be based on their best guess. So to really try to address all the clinical indicators that we will see, it's best to just give the smile designers very specific instructions. So after that, we'll go ahead and do our step 1, step 2, step 3, and then we have our smile design set up. And again, just a reminder, the overcorrection past the ideal will always vary between 0 to 2 millimeters. Finally, after that, after you have your smile design beautifully planned out, you want to make sure you support your force systems with your clinical adjuncts. So with your bite turbos, with your elastics, as needed. So you want the overcorrection that you include into your smile design to be planned in harmony with your clinical mechanics. So meaning you want to be very proactive in how you want to support these vertical movements. So for example, when you have deep bite cases, you generally want to use anterior bite turbos to help with that bite opening. So on the opposite side, if you have open bite cases, then you want to use posterior bite turbos to help with some posterior intrusion and bite deepening. Similarly, for elastics, anterior vertical elastics can be used for open bite cases, and posterior vertical elastics can be used to help with your deep bite cases. So it's always good to keep in mind when you're doing the smile design, how you're planning on supporting all of the force systems created in your smile design when you are chairside. So this is another example. This is a patient with an open bite tendency. And on the upper arch, you can see less than 2 millimeters of crowding, so probably not having much of a bite opening effect there. On the lower, there's about 2 to 4 millimeters of spacing. And then with the IPR that you are planning on the lower arch to help with that lack of overjet, you probably anticipate to be at about 1 millimeter of bite deepening. Your initial overbite is at 0 millimeters. You then take into account that you will have 1 millimeter of bite deepening. Both of your upper and lower incisors start in an intruded position, so they both could benefit from some extrusion. And you do want to, keep in mind when you're doing your consultation to let the patient know that potentially anterior vertical elastics may be required to help support that deepening of the bite. So for your instructions to your smile designer, again, as specific as possible, can instruct them to overcorrect to 3 millimeters of overbite by extruding both the upper and lower 2 to 2.5 millimeters past the ideal. And again, that is because both your upper and lower incisors are a bit more on the intruded side, and so they can both benefit from extrusion. And then we'll go ahead and add 0.3 millimeters IPR between each contact from lower 4 to 4, which you've already anticipated when calculating for your setup overbite. So for this, you do have a deep bite tendency case, the patient looks like they're in, a little bit of an open bite, but there is a lot of spacing going on. So in your upper arch, you have between 2 to 4 millimeters of spacing, which equates to about 1 millimeters of bite deepening. On the lower arch, you have between 4 to 6 millimeters of spacing, which is around 2 millimeters of bite deepening. So start off at about 1 millimeters overbite. Your closing the spaces will result in about a deep bite of 4 millimeters. You want to counteract the unfavorable deepening of the curve of SB in the lower arch from all of that space closure. And then I'm going to keep in mind anterior bite turbos and posterior vertical elastics may be needed for the deep bite tendency. So again, your specific instructions to the smile designer for this deep bite tendency case can then be overcorrect to 0 millimeters of overbite by intruding the lower 2 to 2 by 2 millimeters past the ideal and placing the lower 3s in between the lower 2s and 4s to create a reverse curve of SB. So again, this is to address the curve of SB that you will be getting from all of that space closure. So just a reminder again, our systematic approach to vertical correction is always step 1, measure your initial overbite with your transparency and grid tools. Step 2, estimate your effective crowding, spacing, and IPR on your overbite. Step 3 is to request for the necessary overcorrections for the overbite, being as specific as possible. And step 4 is to support your vertical correction with your clinical actions. So we also have the InBrace toolkits in addition to our InBrace reference guide. Each toolkit will then expand on the smile design module and reference guide by showing a variety of example cases and how to systematically approach them. So the few cases that we've just discussed, we have similar ones in this toolkit that will walk you step by step on, all 4 steps and what kind of instructions could be given for that specific case to the smile designers. So we have looked at thousands of cases, and from looking at all of these cases, the clinical team and the engineering team have come together to come up with an algorithm to go ahead and create the InBrace Intelligent Force systems that I know many of you probably have heard of by now, and some of you may have opted in already for the IFS. So basically, the IFS is movements that will be added to your approved InBrace smile design to help improve the predictability of tooth movement based off of the algorithms that we've come up with. So adjustments may be made for space opening and closing, overcorrections for root tip, root torque, rotations, and virtual power chains. So essentially, these are a lot of the things in number 4 and number 5 of the reference guide. However, providers are still responsible for adding in the standard orthodontic overcorrection movements, so meaning your vertical, your AP, and your transverse, which is why today's webinar is specifically on vertical. So those 3 things must still be added before your approved smile design. And options for early access for opting into IFS are currently underway. So definitely a huge thing to look forward to. So now that we've gone over the smile design, we just want to go ahead and jump into our clinical approach and clinical decision making, which is covered in module 2 of the mini residency. So some of you may have heard me gone over this before, but basically one arch fittings are definitely helpful in multiple ways, and they are also helpful when we have vertical discrepancies. So we generally are recommending doing one arch fitting per appointment. It's generally more comfortable of an adjustment period for the patients. It's also more manageable for the patients and the staff. So you essentially eliminate a 90-minute 2 arch fitting appointment, and you break it down into 2 60-minute 1 arch fitting appointments. For deep bite cases especially, most of the time the lower arch is fitted first. The lower arch generally has more crowding and requires more time than the upper arch to unravel the crowding. So jumping on that first is beneficial. It's also helpful because the lower crowding will help with your bite opening as that crowding unravels. If we had started with the upper arch, this would often require in larger bite turbos that could cause movement of the lower arch and compromise your indirect bonding process. Versus if you have the bite slightly opened already by unraveling the lower crowding, then you may not need the bite turbos that are as big. So some cases though, it definitely is still helpful to start with upper arch fitting. For example, if your patient is in an edge-to-edge bite and you don't want the patient to go into an anterior crossbite from that unraveling of crowding, definitely a case to start with upper fitting first. In this case, you also don't really expect any occlusal interferences and bracket collisions, so bite turbos would not be needed. So this would be a very good case to start with upper arch fitting first. When we talk about IPR, we definitely want to perform our IPR proactively rather than reactively, especially when you have open bite cases or open bite tendency cases where proclination from that anterior crowding will lead to that unfavorable side effect of relative intrusion. So if you look at the before and after of this case, the IPR was not performed in stage 1. So we started off with open bite tendency, and because the IPR was not proactively performed, we exacerbated the open bite, and we now require round tripping of the incisors and also elastics to help close the bite again. So this is an example where the IPR was performed early on proactively. So same thing of open bite tendency case with lower crowding. IPR was completed during the stage 1 and initiated at the initial fitting appointment. And then 3 months later, you can see that most of the lower crowding has aligned and the open bite tendency was controlled without the need for elastics because the IPR was performed early in stage 1. So now we talk about some bite turbos. Generally in the anterior, we like to use flexible anterior bite turbos like Telio. And in the posterior, we use your typical posterior bite turbos like Banlock. For our deep bite cases, definitely recommend the anterior bite turbos to help with some intrusion. And then sometimes when the upper 2-2s are very retroclined, consider placing your anterior bite turbos on the upper 3s. And then for your open bite cases, generally we place posterior bite turbos on the upper teeth, and that way you can get a little bit of posterior intrusion to help control further bite opening. And just in general, I would say it doesn't always have to be just posterior bite turbos or just anterior bite turbos. Anytime that you note that you have the potential for the patient to occlude on brackets, definitely consider placing anterior bite turbos because constant occlusion on brackets can lead to enamel wear, and that is a very similar thing, whether it's traditional or InBrace. You don't want your teeth occluding on the brackets, and so I do have some patients where generally we do posterior bite turbos for their specific case, but because they are heavy grinders, I find that they often grind through the posterior bite turbos pretty quickly. In that case, I have had cases where I also add anterior bite turbos too, just in case they grind through their posterior bite turbos, they still have a layer of cushion on the front so that they are not directly hitting the brackets. And in general, these are our elastic guidelines when it comes to InBrace. Always have to keep in mind that, InBrace is definitely a more flexible night-tie smart wire. You really don't have the rigidity of a large stainless steel arch wire. So we want to keep elastics on the lighter side because with our vertical corrections, we want to have extrusion of, for example, upper 2-2 or lower 2-2 as a unit. We don't want to overpower the smart wire and end up with single tooth extrusion. So we generally don't recommend starting vertical elastics until in SmartWire 2, and we'll keep them light around 2 to 3 ounces. And then if needed to go to SmartWire 3, we can use medium elastics at 4 to 5 ounces. This is common elastic anterior vertical patterns that we'll use for patients. My favorite is generally the one in the middle where we will we'll hook the elastic around the IP loop between the upper ones, and then we'll run those to buttons on the lower 2s. That way we don't need attachments on the upper 2-2 for the patients. Sometimes though, we do find that the patients, if they have an inflamed incisive papilla, it's not quite possible to hook it around that IP loop between the upper ones. In that case, we may decide to use 2 elastics and run them from the IP loop between the upper right 1-2 to the lower right 2, and the upper left 1-2 IP loop to the lower left 2. So in that case, we would use an 1/8 inch 2.5 ounce elastic. For the one in the middle, we generally will use a 3/16 inch, around 2.5 ounce elastic. And then lastly, if the patient is really struggling, they find it very difficult to hang the elastic on the IP loop. Of course, we can always use the pattern we're very used to, the box elastic around all 2s. And in that case, we would use around a 1/4 inch light 2.5 elastic. Sometimes the upper arch, there are cases where they need to be debonded first to allow for settling. So in this case, you can see that the patient is hitting on the upper brackets, and so it makes it very difficult to try to increase that overbite. So in this case, you can see the patient was debonded for the upper arch first, and we are running elastics against the upper Essex, and those are just teardrop cutouts onto the upper Essex so that we can continue to deepen the overbite. So in this case, you can see that nighttime class 3 elastics of 3/16 inch, 4.5 ounce was worn along with anterior vertical elastic, 5/16 inch, 2.5 ounce to work on that overbite and overjet against that settling retainer. And in 6 weeks, we did the lower debond, and you can see the overbite is much deeper than when we did the upper debond. So let's move on into case studies now. This is first case with a patient with an anterior open bite. So these are the patient's initial records. Patient is a 31-year-old female who presented with the chief complaint of her edge-to-edge bite and spacing. She didn't want to deal with the hassle of aligners and did not want traditional braces as a working adult, so she opted to go with InBrace. So while looking at the case, some areas that we'll focus on is the overcorrection for the vertical and the class 3 for the smile design. And then we'll look at clinically how to approach it with inner arch elastics, and then how to progress through the standard treatment sequence. So looking at this case, we already talked about, we know there's the open bite. We know that there is a class 3. So when we do our vertical instructions, we want to ask them to overcorrect to a 3 millimeter overbite by extruding the upper and lower 2-2 by 0.5 millimeter past the ideal. For the class 3 tendency, we do plan on having early class 3 elastics from the lower 4s to the upper 6s. So we will ask them to add 5 degrees of distal crown tip overcorrection to the upper 6s. In this case, because the patient is already open by tendency, we don't want any further premature occlusion to open the bite. So we will add 0.3 millimeters of intrusion overcorrection to those lower 4s. Nothing to worry about in the transfers for this particular case. For the arch length discrepancy, same thing to help establish that proper overjet. We are planning on adding 0.3 millimeters of IPR from lower 4 to 4, and also because the patient has the undersized upper lateral incisors, so we know we need to do a bit more of the lower IPR. So finally, for the individual tooth assessment, usually I like to tell any providers I meet with, remove any tooth movements added to the smile design that are not necessary for you to achieve your goals. And oftentimes, if there's any single torque movements that are really unnecessary in the smile design, I always tell providers feel free to just request to have them removed. And I always tell providers add any adjustments to level and alignment per provider preference. We want to add in any overcorrection to individual tooth movements that would require an increased force level. In this case, there was none. For the rotation tip side effect, in this case, the patient did have a little bit of that rotation on that upper left one. You do see that it will have some mesial out, distal in rotation, which will lead to a distal root tip side effect. So we'll ask them to add 3 degrees of mesial root tip overcorrection to the upper left one, keeping the distal stable and extruding the mesial. And finally, For additional virtual power chain, we would ask them to add 0.3 millimeters of that additional virtual power chain between that upper left one too, because you can imagine as that upper left one rotates mesial out, the tooth is rotating away from upper left two, and so just to prevent any potential small spaces from opening. Essentially, everything that I just went over in that individual tooth assessment is basically will be overcorrected for you if you decide to opt into IFS. So those are things that you would no longer need to worry about. But again, the first three, the vertical, AP, and transverse, that definitely must be added into your smile design. So anytime we're ready for a fitting for a case, we always want to start out with the treatment instructions. In this case, pretty straightforward. Don't see a lot of colors, meaning there's no teeth that need to be direct bonded later. There's no brackets that need to be repositioned. Not really an expected collision with brackets. So everything starts out in its ideal planned bracket position. For your fitting appointment, initially, we were trying out a lot of different upper fittings, lower fittings, dual arch fittings. So in this case, the patient did have the upper and the lowers fitted together. IPR was performed early on proactively. And then we already knew that we were planning on starting early class 3 elastics. So we bonded clear buttons for nighttime light class 3 elastics, 1/4 inch, 2.5 ounce. So to go over the elastic overcorrection guidelines for the AP, in SmartWire 1, we generally suggest light elastics of around 2 to 3 ounces. Once you get into your SmartWire 2, that's when you can move into your medium elastics of about 4 to 5 ounces. And then finally, if needed, in SmartWire 3, heavy elastics of greater than 6 ounces. So slightly different from our vertical elastic guidelines. So this is appointment 2. If we remember, all the brackets started off in their planned bracket positions. So we performed any IPR as recommended. And then the remaining goal for stage 1 is to allow SmartWire 1 to fully express and to complete the initial leveling and aligning. So at this point in time, we're pretty much at the end of stage 1 and ready to begin stage 2. So we went ahead and engaged the upper and the lower SmartWire 2. We bonded buttons to start nighttime light vertical elastics because we are now in SmartWire 2. We used 3/16 inch, 2.5 ounces. And then for the class 3 elastics, since we're now in SmartWire 2, we switched to medium strength, 1/4 inch, 4.5 ounces to continue those class 3 elastics. And here you can see the pattern that's going on, the class 3s on the side and the anterior vertical elastic. So just a reminder again, the vertical elastic guidelines are slightly different. We do want to keep them on the lighter side to prevent single tooth extrusion with the elastics overpowering the SmartWire. So generally don't recommend running vertical elastics until in SmartWire 2. You want to keep them light at 2 to 3 ounces. And then when you're in SmartWire 3, if needed, go ahead and move up to medium elastics around 4 to 5 ounces as needed. So now we're at appointment 3. We continue the same elastic pattern. And then we move on to appointment 4, where looking at our stage 2 goals, the SmartWire 2 is about fully expressed, which may typically take up to 4 months. We have resolved or are pretty close to resolving our inner arch discrepancies. And then in this case, we didn't need any bite turbos, but if we had bite turbos, should be about the point where you can remove or reduce the bite turbos. So at this appointment, we were ready to take our records for digital enhancement. And then with digital enhancement, just always remember less is more. Essentially, you're treating your digital enhancement like wire bending. You wouldn't wire bend a bend for every single tooth in the arch. You usually keep them specific to your needs. And so try to keep your instructions for your digital enhancement as specific as possible. In this case, we wanted to do a little bit more IPR to continue to tuck the uppers in for the overjet. We added some tip corrections and then added some virtual power chain. So at appointment 5, we delivered the upper and the lower DE SmartWire 2, and we performed the lower IPR that we have prescribed in there. At this point, we stopped the right side class 3 elastic since the patient was class 1 on the right side already, and we continued the left side class 3 elastics as well as the vertical elastics. We also bonded a button on upper left 3 to start midline elastics from the upper left 3 to the lower right 2, again using light 5/16 inch 2.5 ounce elastics. At appointment 7, we can see pretty much our elastic wear has been pretty good. Everything's pretty much corrected. We just need a bit of final detailing. So we took records for upper digital enhancement to do the final detailing and to close some residual spaces. And you'll notice that in this digital enhancement, we have even less instructions to the Smile Designer, and all the instructions are very specific. So just kind of like the digital enhancement, second one is similar to just, adding a little bit more to your bend. That bend might not have been enough, so you're going to increase it a little bit, or might have missed a bend, so add that one in, but should be getting pretty close. Instructions should be becoming less and less. So at appointment 8, we engaged the upper DE2 SmartWire 2, and we performed our prescribed upper IPR, and we continue the same elastic pattern. And then at appointment 9, the patient is pretty much ready for debond. Patient came in for a debond check. We happened to have the time, so we just went ahead and did the debond. Normally, we would suggest just as soon as the patient is ready for the debond, try to get them in for the debond as soon as possible. Doesn't matter which modality it is. Patients sometimes will break things, break wires, break brackets. And so just to minimize the possibility of having them break something and then having side effects from that, we generally just like to do our debonds as soon as the patients are ready. So total treatment time for this case, 9 appointments, 14 months, and that's initial, that's the final. So just to go over the key nuances for this case, in the Smile design, we did overcorrect a projected open bite towards a deep bite. We added our overcorrections for AP, so our 5 degrees of distal crown tip to the upper 6s for our class 3 elastics. And same thing, because the patient is already in an open bite tendency, we don't want to potentially extrude those lower 4s when we wear the short class 3 elastics. So we added the intrusion to it as well. For our clinical approach, we use light 2.5 ounce class 3 elastics when in upper lower SmartWire 1. So we already anticipated that we would need early elastics, but we kept them light and did not move on to the medium 4.5 ounce elastics until we were in upper lower SmartWire 2. And then for our vertical elastics, we kept them light at 2.5 ounces and did not start them until we were in upper lower SmartWire 2. All right, so I am going to hand it back to Dr. Lee to go over our second case.
Yeah, thanks, Dr. Pye.
Thank you for that. Maybe at this halftime switchover, we can stop for some questions here.
Sure.
So I got, let me see, these 2 questions. In the deep bite cases, what is the recommended appointment interval between fitting the lower arch and the upper arch to allow for some alignment of the bite opening?
Honestly, it just depends on the severity of the deep bite. What the deep bite is attributed to, whether it's a lower curve or SPE, you retrocline upper incisor. I mean, there's a lot of different factors with that. So, if it's a fairly severe deep bite, you probably will start with the lower arch first. You would let it play out, and you just kind of react based on how it's leveling. So most of the time, we probably would see the patient back, like 8 weeks, 8 to 12 weeks, see how it's doing. It also is just dependent on like how much crowding you have. So for example, if you have, you don't have all the brackets in the right spot yet, then you might see them a little bit sooner. While if you have all the brackets in the correct spot, then you can go to SmartWire 2 a little earlier. So there's just a lot of factors to say, but on average, we tell people about 8 weeks.
Okay. Dr. Pye, what was your estimated treatment time and what was the actual treatment time for the case that you just showed?
I would say we were pretty accurate. Our estimated treatment time was around 12 to 14 months, and then we did end our treatment at 14 months. So because we planned everything out when we did the smile design pretty proactively, so everything moved along as we had expected.
Now, another doctor asked, we use membrane retainers post-treatment, but we noticed that the tissue is very inflamed. So we hold it in an Essex for 6 weeks or so. Would you recommend settling elastics during this time?
It just depends again on the case. So if it's a case that needs settling elastics, then I would say that that's totally fine to do. We do a lot of settling elastics though with InBrace in the lower still, with upper debond early. So I'd say most of the time we don't really do that because a lot of times you place the fixed retainer on the lower arch and then the lower has the inflammation. So normally if they can't get the fixed retainer on, I'll just give them temporary Essex retainers. And if you're going to use fixed retainers, then we'll add it on like a month later.
Okay, that's it. That's it for now, Dr. Lee.
Okay, cool. So we're going to go posterior open bite case now. So this patient was a 32-year-old female. She had a history of TMJ, where her GP had actually previously put her in a splint that had caused a posterior open bite. You can see that she previously had treatment. She had a lower fixed retainer. That GP that gave her the splint then quoted her $40,000 to have crowns placed on all of her posterior teeth. She was no longer in any joint pain. When she came to me, she was a friend of a friend. And I told her that, she has a premature anterior interference that's causing the posterior open bite. While I can't fix her, I wouldn't be able to promise that I could fix her TMJ disorder. I should be able to fix her posterior open bite, and then we can evaluate the TMJ disorder after that. So she didn't want the visibility of braces as a working adult, and then she didn't want to deal with the hassle of aligners. So we went ahead and submitted her for InBrace. And what we're going to focus on in this case is how to address a posterior open bite, and just the general clinical approach of using vertical and class 3 elastics again, and how to progress through a standard treatment sequence with InBrace. You'll find that whether, again, it's an easy or a difficult case, that standard treatment sequence is generally the same for about every case. So looking at the records and planning the smile design, because she has a premature anterior interference, I wasn't quite sure where her bite would be. So I didn't add any vertical overcorrection at this point. My main goal is adding the correction to actually resolve that premature anterior interference. So we just left it as an ideal 2 millimeter overbite. Usually with a premature anterior interference, there's 3 things that I'm kind of looking at. It's whether I need to do some class 3 elastics, add some torque to the upper incisors, and do some IPR on the lower incisors. So in this case, I'm going to do some class 3 elastics on the left side. That should help with the midline as well. I planned on running it from the IP loop between the lower 3-4 to the upper 6s, particularly on the left side. So I just added some distal crown tip to the upper left 6. For transverse was fairly normal. We're just uprighting that lower left side. So that's why we're planning on using some elastics to help that uprighting. And then planning some lower IPR. So about 0.4 millimeters of lower 4-4 IPR, which should help with the premature anterior interference. For individual tooth assessment, we're just double checking that to add any ideal tooth adjustments, that we're taking out any unnecessary movements. Added a little bit of overcorrection to the lower left 4 because you can see in the pano, the lower left 4 could benefit from some distal root tip. That would be taken care of in IFS for you if you opt into the early access. She didn't really need anything for the upper central incisor rotation tip side effect or for virtual power chain. So looking at the treatment instructions, almost all the brackets start in the planned bracket position except the lower right 3, where the lower right 3 is in an offset position. So at the fitting appointment, we put the upper and lower arches on. This patient came from quite far to see me, over an hour away. So she requested to have both upper and lower arches put on at the same appointment. And then we did some lower IPR to help mitigate some of the lower incisor flaring. We repositioned the lower right 3 bracket via direct bonding, and then we finished the prescribed lower IPR. So it was really important, again, to do lower IPR. And then at this appointment, we also started some elastics to help with that premature anterior interference. So we started the class 3 elastics. Because we're in upper and lower small bore 1, we kept it light. It's a 3/16 inch, 2.5 ounce elastic, just worn about 12 hours a day. And then we also started a vertical elastic from the upper right 2-3 IP loop down to the lower right 3, because I actually wanted to bring the upper right 3 down. So I was okay with getting kind of more single tooth extrusion from that one. So that's why we were doing early elastics there, as well as an early cross elastic, because there was premature anterior interference there. In the next visit, you can see that we essentially resolved the premature anterior interference. The posterior open bite is essentially closed. We're double checking the bracket position on lower right 3 to see if it needs to be repositioned again. We can see that the bracket position is good. So again, I always double check any bracket that's had to be direct bonded in the following appointment, and then repositioning it again if needed. So in this case, it was good. So looking at the stage 1 goals, we have all the brackets in the planned bracket position. We finished all the prescribed IPR, and we've let because goal number 1 has been achieved, we've allowed that SmartWire-1 to fully express for that last 2 months. So we're ready to move to stage 2. So in this same appointment, we engaged the upper and lower SmartWire-2, and then we continued the left side class 3 cross elastics. We actually stopped the vertical elastic on the right side, but on the left side, we're continuing the class 3 elastics up with the midlines. In the next appointment, we're just adjusting the elastic pattern. I was trying to get a little bit more bite settling. I was trying to bring that upper left 4 down as well. So I put a button on the upper left 4 and switched to like a class 3 cross triangle elastic. At this point, with the stage 2 goals, we're pretty much done with them. We've allowed the SmartWire-2 to express for the last couple months. They're going to continue to express while we're waiting for digital enhancement wires. We've generally resolved most of the interarch discrepancies. Still could use a little bit more class 3 elastics, but overall is looking pretty good. And then at this point, the bite turbos have been reduced enough that the patient's essentially in occlusion in the posterior. So then we went ahead and took records for digital enhancement for final detailing. When you're doing your detailing, I always tell people less is more. Kind of approach it how you approach detail bending a traditional arch wire. So we just did some minor detailing. So I did some mesial, I added like a mesial out bend for upper left 1, so like a distal root tip bend for upper left 1. So when I'm looking at this, I'm really seeing kind of how am I adjusting the SmartWire more so than how am I adjusting the teeth. And then we also add, make sure to add a power chain so that there's no spaces opening up while I'm doing my detailing. So in the next appointment, we saw her about 6 weeks later. We engaged the upper and lower DE SmartWire-2. We removed the upper left 4 button. Didn't need that anymore. And then we bonded the button on the lower left 4 to help with a little bit, to help extrude the lower left 4 into the occlusion. And then when the patient came back for their debond check, again, she came from quite far away. So as Dr. Pai mentioned in the last case, a lot of times if the patient comes in for debond check and we have the time, we try to just debond on that same day, just in case, whether it's traditional braces or InBrace. That way we don't have to deal with broken brackets or something of that nature. That may delay the debond. So she came in for a debond check. She was happy at this point. Bite looks really nice. And she decided we're good. We don't need to get the midlines perfect. And we can go ahead and debond at this point. So this case took 6 appointments, 9 months to finish. And again, with the posterior open bite, the most important thing is you got to resolve that premature anterior interference. It's the same whether it's traditional braces, aligners, or InBrace. And so with InBrace, we just did it with a combination of lower IPR, class 3 elastics, and in some cases, you may have to add some upper 2 to 2 palatal root torque. Remember, use light class 3 elastics when you're in upper and lower SmartWire-1. You can use medium class 3 elastics when you're in upper and lower SmartWire-2. You can run cross elastics off the IP loop. So there's lots of different ways that you can utilize that for different mechanics. And then just always remember to reposition your brackets that are indicated to be direct bonded on your InBrace treatment instructions. Always double check the bracket position in the next visit. And as long as it's just a minor inaccuracy, you can go ahead and move forward with it. If it's very far off to one side, mesial or distal, then you should reposition it again. Okay, we're next going to go through a deep bite case. So this is a deep bite case with spacing. This is a 26-year-old female. Chief complaint is her large gap. She didn't think she was going to comply with aligners. She did not want traditional braces as a working adult. So we went ahead and treatment planned her for InBrace. So we're going to focus on how do you take care of a deep bite and spacing. So what is the overcorrection deal with these two things, as well as how do you consider staging space closure from a smile design perspective, as well as from a clinical approach perspective. So when we look at the vertical in this case, she's a deep bite. She starts with about a 4 millimeter deep bite. And then the spacing, if you remember, she has about 4 millimeters of spacing on the upper. That's going to translate to about 1 to 2 millimeters of bite deepening. So we're looking at essentially at like a projected 5 to 6 millimeter deep bite. So usually the limits that we'll recommend overcorrecting to is within about 2 millimeters. So if our ideal is 2, we overcorrected to the limit at this point at about 0 millimeter, about an edge-to-edge bite. By intreating both the upper 2 to 2 and lower 3 to 3 by about a millimeter past the ideal. AP and transverse were normal in this case. For dealing with the space closure, so actually we're only going to be closing about half the space, so we actually only have to account for half of the space closure when you're dealing with the vertical. It's still quite significant deep bite when you account for the space closure. So we're only going to close about half the diastema. The small design team will actually do that automatically for you. But we want to, again, make sure that we're not going to cause too much dumping because it's a very large space to close with a single wire. We'll add also some mesial root tip past the ideal to both the upper ones. And then usually we try to specify the vertical positioning as well. So in this case, because the upper centrals are so much more extruded than the upper laterals, we're actually going to put them level with each other to add a little bit extra vertical force. And then we're also going to add some palatal root torque to counteract the torque loss that comes with space closure. With your individual tooth assessment, go ahead and remove any tooth movements that are unnecessary. So sometimes, again, the small design team may add something that might be unnecessary. A lot of times when we don't have a very accurate prescription, that can happen. Add any ideal adjustments, add any overcorrection as needed. In most of these cases, these are all fairly normal. Looking at the treatment instructions, she's going to be occluding on the upper ones, upper left 2 and upper 3s, but everything else is all the brackets are starting in the planned bracket position. So in this case, we did the 2 fitting appointments. We bonded the lower arch in the first appointment. We bonded the upper arch actually 4 weeks later. The patient was quite eager to get InBrace started, so she requested to get it on earlier, which is totally fine. We just have to make sure to put some bite turbos on, and with the flexible bite turbos, we're able to even get patients with deep bites on fairly comfortably. So because she had a little bit retroclined upright upper incisors, plus we're going to get some torque loss due to the space closure, we placed the bite turbos on the upper canines. That way it's not preventing any torque expression of upper 2 to 2. And then I always try to remind everyone, like, it's really good to place flexible bite turbos anytime you see potential occlusal interferences on the front teeth to prevent any occlusal wear from enamel wear from happening. So in the first appointment, or in the third appointment, first check-in after the 2 fittings, we're at 3 months now. We have completed the stage 1 goals because all brackets started in the planned bracket position. We've let the wires express. There was no IPR planned in this case. And we engaged the upper and lower smart wire 2. Sometimes, though, even though you're placing the flexible bite turbos on the upper 3s, patients still sometimes will bite on the upper 1s or upper 2s. In this case, because the upper 1s are over extruded, she was still biting on the upper 1. So I went ahead and put the flexible bite turbos on both the upper 1s and upper 3s. Sometimes you have to do a different combination of the flexible bite turbos to get them comfortable, as well as to ensure that they're not going to break the brackets. We then took records at this point for an early DE for the upper only for the stage space closure. So I know that even though SmartWire 2 hasn't expressed fully yet, I know it's going to still express another millimeter or 2, and I really want to try to get this going as efficiently as possible. You could also wait until after the upper SmartWire 2 has expressed. So it's just either this appointment or the next appointment, you submit for an early DE for stage space closure. So at this appointment, I'm actually already kind of projecting that there's going to be another millimeter close. So you can go ahead and close the remaining space. We did the same kind of vertical overcorrection, treating the upper 2 to 2 by a millimeter past the ideal. Same overcorrection for the space closure with 8 degrees of mesial root tip past the ideal, 8 degrees of palatal root torque. And then in the next visit, we just engaged the upper DE small wire 2. You can see that the space has closed quite a bit since the last appointment. Now we have about like a millimeter and a half space, while before it was quite a bit larger. So that smart wire 2 has actually expressed that like about another millimeter while we were waiting for the digital enhancement wires to come in. So then we engaged the digital enhancement smart wires. When the patient comes back about 10 weeks later, you can see the space is essentially closed. It's about maybe half a millimeter space left. So at this point, we took records for digital enhancement. This time now we're kind of looking at final detailing. So we're looking at detailing both the upper and lower arches. At this point, we also decided to put some buttons on to help with the midlines. Midlines are just very slightly off. Left side is very slightly class 2. So we bonded some short class 2 triangle elastics from upper left 3 to lower left 4, 5. running a 3/16 inch 4.5 ounce elastic. At this point, we're just doing the final minor detailing. So we just added any ideal adjustments to the leveling aligning that we wanted for both the upper and lower. We added a little bit more overcorrection again for for the deep bite correction on the upper. And then because there was a little bit residual space still between the upper ones, we added some additional virtual power chain to make sure that that closes. That's something that now we add for you automatically through IFS, so you wouldn't need to worry about that. Another thing we added in was the lower right 3 needed some rotation and the bracket was very distally offset. So we kind of had a decision of whether to reposition it or just add some rotation overcorrection. And in this case, we just added some rotation overcorrection. Usually sometimes adding 3 to 5 degrees of that rotation overcorrection on a very offset bracket can help let that tooth express a little bit better. So in the next visit back, we put on the upper and lower DE2 smart wire 2. So this is actually the first DE for the lower, second for the upper because of the stage space closure. We're still continuing the same elastics on that left side. When the patient comes back 2 months later, patient came back for, we're at a debond check now. Spaces have all closed. Alignment looks really nice. The only concerns the patient has at this point are she doesn't like the black triangle between the upper ones. So in retrospect, I probably should have planned some IPR on the upper ones in that last digital enhancement. And then some spaces formed between the upper 6s and 7s. No concerns on the lower arch. So we actually just went ahead and debonded the lower arch of this visit because the patient was good with that. We put a retainer, we left the buttons on, we're still running the same class 2 elastics with the S6 retainer. So we did a final DE just so I could do some IPR on the upper ones to close the space, as well as to bond some brackets on the upper 7s to close the space between the upper 6s and 7s. Could have very easily done this with active retainers as well. So I could have just done some IPR, given her a few active retainers to close both the spaces on the upper 6s and 7s and the upper ones. Would have also been a very good option. But we went ahead and did this with InBrace. That's where I last left off with this patient. Next week, next visit, we're going to actually deliver that upper DE3 smart wire 2. We're going to bond the upper 7s, perform some of the upper IPR between the upper ones so that we can close some of that black triangle. Following visit will be debond check, potentially even debond on that visit, and then debond on the following visit. So in this case, kind of the nuances to keep in mind is when you have deep bite plus space closure, particularly a large diastema, you're going to be having to looking at overcorrecting the vertical, the tip, and the torque to counteract all those side effects. The overcorrection for space closure, so the tip and the torque that I was discussing, that's all covered by IFS if you do your early opt-in for IFS. For a large space, somewhere between 3 and 6 millimeters, you should only close half the space. If you're doing something like, say, like an extraction space that's even greater than 6 millimeters, usually we'll only close about a third. So it's staged into multiple components. When you do have an offset bracket position, if you still have a good amount of movement left, it's better to reposition. However, when you're in that final detailing, sometimes it's more predictable instead of having to repo a bracket and have some of that error with repoing a bracket, just to add some rotation overcorrection. For clinical approach, when you're doing your stage space closure, generally you'll submit an early DE. If it's an upper diastema, you just have to do an upper only DE during or after smart wire 2 expression. Okay, last case in the last few minutes is one on a posterior gummy smile case. So this case is 32-year-old male. Chief complaint is his gummy smile, misalignment of his front teeth. He had braces when he was a teenager, didn't really wear his retainers. So he knew that he wasn't going to be good with retainers or aligners. Didn't want braces as a working adult. So we went ahead and did InBrace for him. So we're going to focus on how do we address this gummy smile. He also had a posterior crossbite. So we're going to look at how to use TADS with InBrace. And this is a case when you're going to use smart wire 3 because it's a little bit more complex. So from the vertical, he does have an open bite. However, I am planning on doing some posterior intrusion with TADS. So I didn't feel the need to overcorrect the overbite because I actually want to get some of the bite correction and see how much bite correction I get from like the auto rotation from intruding the posterior teeth. AP, we didn't do any, is fairly normal, so we didn't do any at this point. We expanded the upper arch by 3 millimeters past the ideal. It's mainly going to be achieved by dental expansion, but the patient was okay with having some tipping of the teeth out. We did add some buccal root torque to the upper 6s and upper 4s and 5s, so about 10 degrees to the upper 6s, 5 degrees to the upper 4s and 5s. Could have even considered doing more. That might have actually helped control this a little bit better. We didn't do any IPR at this point. And we just did our general individual tooth assessment. Nothing to note in this case. In the treatment instructions, upper left 2 was off-centered. Lower right 1 was a bond for later, so we're going to bond that tooth later. And there's some. So in the fitting appointment, we went ahead and fit the upper and lower arches in this case, engaged upper and lower smart wire 1. For lower right 1, we direct bonded the smart wire, directional bonded the smart wire locket. When he came back 2 months later, usually anytime there's an off-centered bracket like upper left 2, or there's a directional bonded bracket like lower right 1, or directional bonded small wire locket like lower right 1, where it's not too severe of a rotation, I know that I can get a bracket on the next appointment. I know that I can write that in my next visit notes. My staff knows to have that all set up. So we went ahead and repositioned the upper left 2 bracket, direct bonded the lower right 1 bracket, performed some of the upper and lower IPR. And then at 4 months, we checked the upper left 2 and the lower right 1 bracket positions, verified them to be a good position. Again, always double check your direct bonded bracket positions. We bonded all brackets in their planned bracket position. So all brackets have now been placed in their planned bracket position. All IPR has been performed. And since we've achieved goal number 1, we're going to allow smart wire 1. We've allowed smart wire 1 to fully express. We went ahead and engaged upper and lower smart wire 2. At this point, we're going to start the TADs, the posterior intrusion with TADs. We bonded 1622 stainless steel arch wires from upper 5 to 7. So I put brackets on the 6s. I just bonded the wire directly to the 5s and 7s. And then we placed TADs between the upper 5s and 6s, and then just started running power chain for upper 6s and TADs. So we're just, for the next 3 appointments, essentially, we're just going to be intruding with the power chain. So we engage upper smart wire 3. I was trying to get a little bit more expansion as well as a little bit more torque control by having a full-size wire in. And we continue retying the power chain. At this point, at 8 months in, I'm seeing that there are some detailing things I could start working on. Even though technically we have not finished our inter-arch correction, I do see that I know that this inter-arch correction is going to take quite a bit longer, and I would like to start doing some detailing. So this is a reason why you could do we'll call it mid-course digital enhancement submission. So usually you do a mid-course digital enhancement if teeth are not moving properly, so they're not tracking properly, or if something wasn't planned properly, or there's a change in the treatment plan. Once in a while, you also do it when you have a case where you're going to go for, you need a lot more inter-arch correction. You haven't gotten the detailing or leveling where you want it. So then you're continuing essentially in stage 2. Stage 2 is your working phase in orthodontics. You're doing all your inter-arch mechanics. So even though we did an early DE, I still classify this to me as this case is still in stage 2. So we did a mid-course DE. This is not when you have to worry about less is more. This is where we're actually still trying to do some major movements. We're kind of adjusting, I guess, the small design or treatment plan. So in this case, we added some brackets in the upper and lower 7s to help with the expansion and torque correction. We level on the line to ideal. And then we intruded the upper 4 to 7. Again, we want this to work in harmony with the planned TAD mechanics, as well as we added some buccal root torque overcorrection to try to prevent some of the buccal flaring. We engaged the upper and lower DE smart wire 2 in the next appointment. We retied the power chain to continue that posterior intrusion. We kept doing this essentially every 6 weeks. And we put a new smart wire 3 in to continue controlling the torque, as well as continuing to help with the expansion. At this point, I started thinking, okay, let's try to settle the bite, try to improve the midlines. So we started full-time class 3 elastics on the left side because we're in medium strength. Because we're in smart wire 3 and smart wire 2 on the upper and lower respectively, we went ahead and used medium strength elastics, 1/4 inch to 4.5 ounce elastics, as well as some nighttime vertical elastics, 3/16 inch, 2.5 ounce elastics, coming from the IP loop between the upper 1s down to the lower 2s. I felt that in the next one, I felt there was a little bit of canting forming, that there wasn't enough intrusion on that upper left posterior. So I decided to place a TAD between the upper left 3 and 4, and then I started retying the power chains to the upper 6s as well as the TAD between the upper left 3 and 4. At 17 months, I felt the upper left 6 had gotten some fairly good intrusion, so I went ahead and laced that off. The upper right 6 and upper left 4, not quite there yet, so continued to run the power chain there. And at this point, I was also deciding I had some space to start bringing the lower up, so I ran some settling elastics to start extruding the lower posterior teeth. In the next visit, I felt pretty good about the position, the upper right 6 and the upper left 4. You can see that there's been some good intrusion. So we went ahead and laced the tab to them. And then we're continuing those settling elastics to bring the lower, to extrude the lower into the upper arch. So the next visit most likely will take some records for the second digital enhancement, and that will be for final detailing. And so here you can see the progress so far with this case. 11 appointments, about 19 months, but you can see he has a really nice smile arc now, and he's had some good posterior intrusion. So recap of the nuances in this case. When you are expanding, you can achieve some dental expansion. You do need to add some buccal root torque, and you often will need to add, say, a SmartWire 3 to help with the planned tooth movements of this expansion, as well as to control the torque. This case also, from a clinical approach, you can see that complex tooth movements can be performed with InBrace in combination with, say, like auxiliaries such as TADs. And then to keep in mind that stage 2 is that working phase of InBrace treatment. So even if you did, say, a mid-course digital enhancement, that doesn't mean you've completed all your goals of stage 2. So you should still always complete every goal between stage 1 and stage 2 as you're going through the standard treatment sequence, and use SmartWire 3 when additional force or stability is required for the planned tooth movements. So that's it for this webinar. We will present this webinar again on Thursday, October 19th at 9 a.m. Pacific time, 12 p.m. Eastern time. And then now we can open it up for any questions.
Thank you, Dr. Lee. Beautiful cases there. So we do have a few questions coming through. So let me see here. We had a couple questions regarding when you run elastics to IP loops. So do you find that the elastic wear leads to increased incidence of breakage of the wires? And do you add in any overcorrections when you're running elastics to IP loops?
No, not really. So there's no incidence or increase in breakage from IP loops. Do it all the time. Never had a wire break because of that. I do only use light elastics usually, at least for the vertical. Once in a while, like for a class 3, like I showed in the second case, you can do a medium strength. You will find, though, the thicker you get, it's harder to get around the IP loop. So you probably wouldn't be able to get anything bigger than that on anyway. Don't normally need to add any particular overcorrections because you're running it to the loops versus what you would already do for, say, like a class 3 elastic or a class 2 elastic for like the distal crown tip. Yeah, so normally for like open bite correction, you don't need to add as much if you're going to run elastics because the elastics will essentially get you to that ideal if the patient's wearing it well.
Okay, with the post debond IPR, how do you manage avoiding hyperocclusion in the anterior?
With the post debond,
I think it's asking just your
post debond.
I think if you did the upper debond, then add a lower IPR.
Why don't you just go through sort of your I think it's the case when you're using the elastic the Essex, right? Is that it?
With the post debond IPR, how do you?
Okay, doctor, if you can ask that question again, because yeah, I'll move on to the next question.
Okay.
This was around 558, so this was your last case. Will the DE wire add more buccal crown torque on those upper anterior, or plan to mesialize upper teeth?
Oh, okay. Yeah, for the this is for the spacing case, I think. For the spacing case, yeah, we did add some palatal root torque, buccal crown torque to the upper anterior. So yeah, with the DE wires, we did add some overcorrection for that as well. So yeah, sometimes you do get with space closure, you do get some torque loss. So that's why it's always easier to prevent torque loss than actually try to add it back in. So first thing for that is, again, add sufficient overcorrection for the space closure. So we actually do that again now for providers that have IFS. But if you did get any torque loss, then you do have to add quite a bit to try to recover. So sometimes you're looking at adding like 10 to 15 degrees past the ideal if you ever really needed some good palatal root torque expression on the upper 2 to 2. And sometimes you do need to go to smart OR 3 when you are trying to achieve more palatal root torque upper 2 to 2.
And I guess the question was about the case where you debonded the lower arch first. Can you just walk through that again real quick?
That's the deep bite case as well. Oh, in this case, the patient had excessive overjet, and we were even running class 2 elastics. She had a little. The pictures don't show it that well, but she had a little bit of overjet, so I wasn't that worried about like a premature anterior interference at that point.
Okay, so lots of great questions here, everyone. I know we're running out of time, so we're gonna have this webinar again this Thursday, October 19th at 9 a.m. Pacific, 12 p.m. Eastern. Or you can go on the in-group and ask a question there if you know, you have any follow-on questions, or reach out to any of us here. You know, you guys can find us on Facebook, or you guys can email any of us here. You know, closing here is I've been getting some great feedback from, you know, all of you in the chat rooms. Sorry, in the chat room we have here. And you know, this information is really just based on the feedback you're giving all of us. So please take the survey that gets sent out, because only through that feedback can we make sure that we're giving you the material that you want, or improve upon the things that we are creating. And if it is helpful, the best thing you can do is please tell a friend to either you know, try InBrace, or providers you may know that are not joining these webinars. You know, please have them join to get this awesome material that Dr. Lee is creating for us. With that being said, thank you everyone for joining, and we'll see you on the next webinar.